En este segundo día del simposio se tiene pensado seguir ampliando los horizontes de conocimiento en cuanto a la atención domiciliaria. Hoy tendremos conferencias de cierre también con invitados nacionales e internacionales, por supuesto de gran trayectoria, y también tendremos 2 talleres prácticos simultáneos para seguir aprendiendo haciendo. Entonces, bienvenidos nuevamente y que sea una excelente jornada para todos. Para empezar el día de hoy les vamos a transmitir la conferencia del doctor Itamar Offer, que en este caso su conferencia es sobre el doctor Itamar Offer va a contarnos la experiencia de Israel en Hospital at Home.
Hello, everybody, and thank you for the invitation for your Congress. It's really a pleasure, and I'm very happy to be here. My name is Itamar Offer, Dr. Itamar Offer. I'm a pediatrician and a healthcare management expert. For the last 25 years, I was running healthcare organizations, different healthcare organizations, and the last 6 or 7 years was in Saba Health, which was a hospital at home initiative that we started, and that's the experience I'm going to share with you in the next 15 minutes. So thank you again, and without further notice, I will just share my presentation, and we'll see what we're talking about. So I hope you see my presentation, and we are going to talk about the implementation of hospital at home in Israel since 2017-18 till date. The main purpose of this presentation is to give you some takeaway messages, actual, practical advice about how to do it. First, we have to remember that we are entering a system, and we entered a system that did not know what hospital at home is. And we had to explain and to educate. And as we all know, strategy is important, but culture is much more important and much stronger. And we have to appreciate it in order to succeed in that initiative. So we have to take some of the old way out and bring a new way in, which is a challenge. When we talk about change, and thanks to DALI and GPT for the nice drawings, on the right you can see technical change with all the cogwheels. On the left you see adaptive change, which I'll talk about in a minute, which is more complex and unclear. So technical change is where the problems are clear and the solutions are known, and it can be solved through existing knowledge and professional expertise. And usually when we want to implement the solution, it doesn't require a change in values or behavior. The role of the leadership is to provide clarity and to take people with them on board. But when we talk about adaptive change, it's completely different. And we as leaders, we have to understand and appreciate it. It requires new learning, new approaches, and new behaviors, and some of the solutions do not exist. We have to invent them and to improve them on the go. And the main point is that it requires changes in values, beliefs, way that we do things, roles, relationships, sometimes money, and operating systems. Sometimes we make mistakes and we have to be flexible to correct them. And the leadership should be guiding people through the change process, creating supportive environment, encouraging learning, and dealing with conflicts, and be patient. Hospital at home is an adaptive change, no question about it. And no change is a small change. It's always big and complex. While preparing for this presentation, I talked with some of you, and thank you, Jaime, for the invitation again. And I saw there are some similarities between the Israeli system and the Colombian system, which are very important in order to implement hospital at home. First, you have national health insurance law. You have a shortage of hospital beds, maybe more severe than ours, but ours is severe enough. Shortage of physicians. Your primary care serves also as gatekeepers, but also maybe gateway. I'll talk about it in a minute. And you already have existing other home care solutions, which are not acute care at home or hospital level care at home. They exist and people understand the advantages. So when we started in 2018, 17, that was the situation in Israel. Sorry for the Hebrew, but those are names of hospitals, and those are the occupancy rates in the internal or general medicine departments. So you can see some of them were 169%, 238, and most of them were above 100% occupancy. And that's how it looked like. You see, when they have personnel for 36 beds, they had 46 patients and 50 instead of 40, etc. That was the occupancy, and those are the corridors, and that's how it looked like. By the way, sometimes in some parts of the year, it continues to look like that. It's a very problematic situation for the patients, for the team, for everybody. That's not good. And we know that there are alternatives to that. In Israel, there were other challenges too, because if we look at the people who are 75 years of age and older, we saw that since 2020, and I'm talking about the beginning, so we were 2017, but in 2020 to 2030, there is a huge raise in the numbers of 75ers and older. If you see here, you can see on the red line that the 80 plus is even more severe. And that's because we were a young country, but we are not a young country anymore. We are getting older. That said, Israel is growing at almost 2% a year. So the whole country is growing, and that population is the fastest growing population. In addition, if we look at the consumption of hospital beds, sorry for the Hebrew, but you'll understand, in 2017, people above 75 were 5% of the population, but they utilized about 28% of the hospital capacity and resources. So you can understand, and if that grows to 6% or 7%, then it becomes a huge challenge in Israeli healthcare. In addition, we know that people above 75 have 4 or 5 chronic diseases that, of course, sometimes they have exacerbations. That's why they occupy the departments, and that's why Israel had urgency to push forward the alternative solutions to hospital beds. If you go to the end, that's what happened. That's the Saba Health numbers, but the country went on the same line. So we at Saba, before COVID, we were at about 100 admissions per month. In the third wave, when we were allowed to treat COVID patients, we jumped to 400 admissions per month. The next wave was 600. And in January 2022, we admitted more than 1,000, about 1,050 patients. And then between the COVID waves, we were stabilized at about 700 admissions per month. In Sabah, I think the whole country was about double that number. The census was, you can see the census here, 27 when we began, 81, 126, and 190. Main point that I want to talk about is what made it possible and how did we grow so well. So I'm going to jump immediately into the lessons learned from the Israeli experience. The first one is health policy. You need the Ministry of Health, you need partners there, and without it, it's very hard to go forward. And they need to be open and positively, look at it positively, and you have to find your partners in the government to push it forward. There are several points in the government, but let's take 2 of them. One is the professional certifications, especially for nurses. When we started, it wasn't clear what is allowed for a nurse to do at home, even when there is an order from a physician. And we had to work with the government on the professional certifications. Some of it was first we approved to do it as a pilot and then officially provide certifications. They relied on our professionalism, and together today, all those certifications are in place and the nurses can do at home almost everything that they are allowed to do in a hospital. The second thing is money. And since the healthcare systems everywhere are very, very tight in terms of budgets, at least, subjectively and objectively. What happened in Israel that we got special funds. It was supporting funds that are outside the main budget in order to push hospital at home forward. And actually that fund sponsored the whole hospital at home initiative. In Israel, we have 4 HMOs, sick funds, which are providing the care to the population. And they got actually reimbursed for every hospital at home day they purchased and operated by themselves. So there was an external funding. And later I will talk what happened with it in several years. In terms of organizational, in Israel, maybe in difference from most of the countries that we are meeting in the World Hospital at Home Congress, except for France, maybe the UK a little bit. In Israel, the operators and providers of hospital at home were, and mainly today still are, private healthcare companies. The rest of the healthcare system is public, and the difference in that manner is that private companies can have flexible employment contracts, and they are not tied under the unions and the general agreements of the different professions. So we were flexible, and we could also improve the employment contracts as we went and as we learned how to do it. We started as a hospice and maybe rehabilitation at home, but when you go to acute care at home, you have to be sometimes very different in terms of the contracts of the doctors, nurses, and other professionals. The second thing is that professionals should work at the top of their license. You have to push as high as you can. We don't have in Israel community paramedics, but they do have in the US, in Canada, and I think they do great work with those community paramedics that are available and a little cheaper than doctors while going to patients' homes. When we talk about telemedicine, I have to say something very important. When we started, all visits were actual visits, physical visits of the doctors, of the nurses. At least once a day a doctor was coming, 7 days a week, at least once a day a nurse, sometimes twice. It all was physical. After about 3 or 4 years, we tried, and together with the Ministry of Health, we defined the situations where the physician's visit can be from a distance by telemedicine, but there was a certain way of doing it. We decided, for example, that if a patient has a fever and let's say a urinary tract infection, and it's the second day and the fever went down and the patient is relatively well, then the physician visit can be by telemedicine. But it happens when the nurse is at the home of the patient. The meaning is that the quality of the visit is much higher, and the nurse can make sure that the patient and the family understands the doctor questions, and the doctor understands what's happening with the patient. It works very, very well. And then we gradually added more indications for hybrid visits, for telemedicine visits. And that was one of the ways to scale, as I showed you earlier. The next one is very important, and I talked about your primary care physicians. When we started, we thought that patients will come from the hospitals, from the ER, or from the departments. Surprisingly or not, it didn't happen, not in any meaningful numbers. And then we understood that our address should be the primary care physicians or the family physicians. And we started working with the sick funds to educate those physicians to identify the patients that fit the definitions of hospital at home, and instead of sending them to the ER, sending them to hospital at home. They were not used to do it. They used to send to ER and someone else is deciding about the hospitalization, but we educated them and it worked greatly. And nowadays, it was 80%. Nowadays, about 75% of the admissions to hospital at home in Israel is coming directly from the family physician desk. And within a half an hour, there is an approval, which I will talk in a minute, and the patient goes home. And within 2 to 3 hours, a physician and a nurse are coming from the hospital at home team, are coming and starting the admission. Our HMOs developed on their digital EMR, they develop pop-ups that when the physician starts writing a referral to the ER, he has a pop-up asking him whether this patient fits the definitions of hospital at home and should be sent home instead of the ER, which works very well and reminds the physicians not to forget that option. One more thing that we have to think about, and don't push it under the carpet, is the avoidance of abuse. One thing to ruin a hospital at home initiative, one way to ruin it, is to abuse the system and to treat people who do not have to be in the hospital at the hospital at home systems. So in Israel, one thing that worked, and I think it's relatively powerful, we started from day one a pre-authorization system that actually every patient is pre-authorized to be admitted to the hospital at home by the payer, the HMO, and by the hospital at home team. The first authorization is for 3 days. And if we want to prolong, and if we need to prolong the hospitalization, we have to to send a professional request again. And usually it works if it's really required. So if we take a look at the Kotter's 8-step change model, Kotter is a very famous change expert from the last century, the end of the last century. So we can understand that we had the issue with the elderly and the growing numbers of the elderly in terms of sense of urgency. We had to create a guiding coalition. I talked about the Ministry of Health. I talked about the HMOs. I talked about the hospitals, that it was a challenge. And only nowadays, 7 to 8 years later, they start collaborating. We called it hospital at home and no other names, no virtual and no hybrid and nothing. Hospital at home, actual patient, actual hospital level care at home. We didn't compromise on that. We communicated the vision through public relations, of course. And one funny thing was that we thought that the patients would resist and the families would resist and the doctors would, etc. And except for the hospitals, everybody was happy and there was no resistance on their side. The hospitals, it took them, as I said, several years to collaborate. We started, of course, with pilots in several areas. And later on, we started making guidelines and to measure and to make sure that we fine-tune the quality of hospital at home. One thing we did not succeed yet is stabilizing the funding, and it is still a support budget by the government, and it is still not in the main central budget, but I hope it will happen in a few years. So I'll go back to the similarities between Colombia and Israel. And I think the main advantage that you have, in addition to the national health insurance law, is go for the primary care physicians, educate them. They are great partners. They feel that it's an upgrade to be able to send the patient directly to hospitalization instead of sending to the ER. The patients are very happy. From day one, 90% of the patients and families said yes, at least in Israel. So that's our experience. Thank you very much. And I wish you a great conference. And I thank you again for the invitation. And see you in the World Hospital at Home Congress that will happen in 2027 next time. Thank you very much.